So it's my pleasure to facilitate today's discussion on why space matters, specifically in healthcare and specifically to maternal and childcare health. So space is not just a physical structure because it plays a crucial role in shaping care experiences, influencing health outcomes, and ensuring dignity, comfort, and accessibility for both patients and the healthcare providers. So as a clinician, I always see firsthand how design is very important in healthcare settings, and it influences the quality of care and again operational efficiency because it helps you to streamline workflows within the organization. And today we have a distinguished panel who will be able to share insights from research, policy, and practice on the role of space in improving healthcare delivery. So to begin this session, I invite Dr. Abha Mehndiratta, Faculty and Improvement Advisor at the Institute of Healthcare Improvement, to first set the stage on why space is a critical factor in healthcare delivery, specifically for mothers and newborns. She'll be providing insights on the Delivering More project. It is a IHI and mass design which have worked across multiple countries to understand how the design and function of space influence the care and health outcomes. Over to you.
Yeah, thank you. Good morning, everyone. I will be presenting on behalf of my colleague, Dr. Minara Chaudhary, who was not able to come. So this is a project that was started in 2021. It is a collaboration between Institute for Healthcare Improvement, which is a Boston-based organization working in more than 50 countries worldwide, and Mass Design, which is a non-for-profit Boston-based architectural firm which is looking into research and advocating for architecture that promotes justice and human dignity. So I want to start to pause and have you reflect on this slide and really make the case for space and why space matters. Spaces are never neutral. They either help or they hurt. And that's why it's important that we think thoughtfully about them. They don't necessarily need to be extravagant, but they definitely need to be thoughtfully designed, keeping the person for whom they're catering for at the center of care. And in the hospital setting, that is the patient we are referring to. Quality care requires quality spaces, for sure. The design of facilities shapes where the families in the first place come to seek care in that facility, and it directly impacts the demand for care. We do know how the services are organized within that space. The layout of those services actually impact whether the patient is able to access the right care at the right time. And we also know, and I'll show an example in my next slide, how design of spaces actually can be an enabler or a disabler to evidence-based clinical practice, which then directly impacts patient outcomes as well as patient experiences. So taking the example of kangaroo mother care, and we will be talking more about this with our distinguished panel, we do know that it's an evidence-based practice. There is immense amount of literature available that if kangaroo mother care is provided early, it will have a positive impact on survival, on child outcomes. But we do know that it's not a common practice. I believe a lot of you have maternal and child health units in your hospital, and kangaroo mother care is usually not the norm, at least not in India for now. And one of the main reasons is that our spaces are designed largely for efficiency, largely keeping the provider and the needs and the comfort of the provider in mind. But if we look and design spaces which makes it easy for the mother, if she has to give kangaroo mother care in that unit for about 18 to 20 hours, is the space designed in a comfortable manner to take care of her needs? For her to have food if she needs, for other family members to come in and share that responsibility with her? Does she have privacy to be able to, in a dignified manner, actually provide that care for her baby? So very important that if we do not have the right space, we definitely will not be able to provide the right evidence-based care, the right care at the right time. And also, I want to mention that, as I mentioned earlier, spaces are often designed for efficiency. But when you're looking into the maternal and newborn health space, they really need to be designed to honor the new birth that's coming and honor cultural practices and local materials that can be used. So I want to give you a provocation. So across multiple contexts, this is what we see, and many of you would also say that we have short-term approaches to infrastructure improvement, which results in patchwork building layouts, sometimes contradicting ideal care flows and experiences. Healthcare spaces are often designed without really engaging the stakeholders for whom they are being created, and not necessarily keeping in mind the local culture of that place. And facility administrators and providers are often doing their best to provide care in spite of the space they have, which in turn puts increasing pressure on already overburdened staff. So a second provocation is that if you remove all those limitations, and if you could put your imagination and creativity, and imagine a world where there is actually a commitment for long-term investment in physical space, which is bundled with other comprehensive initiatives to ensure quality, where there is human-centered design, where the people for whom these spaces are being designed are being engaged, and their input in an iterative manner is informing the space design, keeping in mind the local culture and climatic context. And these spaces are amplified and supported so that healthcare providers can deliver care with adequate motivation. So in parallel, as we go through this provocation and aim for this vision, the Delivering More project has been distilling its learnings, and it has created a number of global products which are freely available on our website. And if you come to the IHI Lounge, one level below, you will be able to see some of these products which are there. And we would really encourage all of you to go through it and see if you find things that resonate with you. So we have distilled our processes and learnings into a human design toolkit for improving maternal and newborn care spaces. This includes a facility design guide, which gives an overview of the design principles that have been used. It includes an engagement toolkit, which shows how the different steps of design take place when infrastructure is being designed, and which are the stakeholders that need to be engaged and involved at different points when decisions are being made for iterative feedback. There is also an assessment tool, because many of you may have existing spaces that may need to be redesigned, and this is more for structural engineers to look at what the existing infrastructure is and what can be done to make it more suitable for the care that needs to be given. And an overview guide which contains the key design principles. So I want to end with this slide. To create meaningful and transformative change, we really must champion longer-term investment in the built environment. Together, we can all deliver more. So thank you very much.
Thank you, Dr. Abha, for the wonderful insights. And it's really nice to see all these tools which have been put out now, because I've been part of building hospitals, and we have not had any structured tool so far. And this will be very useful for others. Thank you. And to move on to the panel discussion, I'd like to hear from each of our panelists on the fundamental question, why is space important in healthcare and how it can enhance the care for the mothers and newborn. So each of them bring their own unique perspectives, and I encourage all of you to have your own reflections on the experiences and other systemic implications. So I'll start with Dr. Nuzat. I have visited your hospital, your renowned hospital, Fernandez Hospital at Hyderabad, which has been established as a center for quality for mothers under Dr. Evita Fernandez. And I would like to know from your experience of designing labor and delivery spaces at the several branches of Fernandez Hospital, what elements of space you consider absolutely non-negotiable during labor and delivery? And also beyond functionality, how can space be designed to bring joy to patients, families, and especially to healthcare providers, because everything happens in very intense settings. Over to you, ma'am.
Thank you, Dr. Abha and Dr. Anu for inviting us, for making us a part of this conference, and I'm absolutely delighted to be a part of it. I also loved your sentence that not involving the the people that they serve. So obstetricians as well as women, I think, and I'm representing both of them. So Fernandez Hospital does about 10,000 births annually, but we have evolved over a period of time. It's a 75 years organization, and in 2010, we felt that we had to change it completely, the way we were working, the way we were providing care and the spaces. So we really turned it around. So let me go to the aspect that obstetrics is not a pathological process for more than 80% of the women that we see. It's a physiological process. And this physiological process is also a transformational one, both for the mother and the baby and for their families. So we have a huge amount of emotional, psychological environment and effect onto this. The second aspect of this physiological process is it is mostly mediated by oxytocin, which is a hormone which can have a huge number of effects from any kind of an stimuli that comes into that woman who's birthing. So, with this little background, the first non negotiable that I would put it up today, I mean, not maybe 10 years ago, would be privacy. This aspect that we somehow always thought that we wouldn't have space to provide rooms for them, and let's put curtains in between, let's put beds one after the other. Actually, we do a huge amount of damage by putting, missing this little concept out of. So today, our rooms are much better, and our rooms provide a complete privacy for them. We also have an additional curtain moving in so that when the door opens, the woman will still be, have a curtain, and we have to ask, can I come inside after that? So this was a non-negotiable that we had. The second one aspect would be space. We would always say that there is no space for the attender to come in, there is no space for other people to come in. Why we always create good enough space for ourselves. This space is not only for her to move around, to sit on a table, but it should also include a bathroom. Because many women feel very uncomfortable to go to the common bathroom which is there, and we felt that we made errors. In our first unit, we did not have bathrooms attached to it. In the second unit, we really tried hard, but the architect said, we couldn't. In the third one, we said that this is a non-negotiable. We have to have a bathroom as part of the labor and delivery room that we were creating. The third aspect was comfort, and this includes not only having a birth attender, but also what is the surroundings like, whether it's a home-like environment that I'm going to create, whether it is her senses that I'm stimulating, the noise levels in that room, or the smell levels, or what she sees, or the number of people. And the most important is that the light, sometimes they have a light for suturing, which should come only if there is a need to after birth. So these are very important aspects that should be taken into consideration for designing a space for labor and delivery, and not undermining the role of safety or a safety environment. And as Dr. Peter said, it should be in the genome of the healthcare providers that we should be able to do a crash cesarean section in 15 minutes and take that baby out if the need be. So I feel that these three important things that I have put it up prior to laying every other aspect that we would have as part of safety and functioning should be the most important aspect of a birthing room.
Thank you.
And I hope others will add into what I said.
Thank you so much, Dr. Nuzhat. Thank you for really reiterating that delivery is a physiological process and space needs to be designed such that it's comfortable for the mother for whom that care is being done. The bathroom needs to be accessible. She needs to be able to access a birth companion, and there needs to be space to move around, and most importantly, there needs to be privacy. So thank you for sharing that. So building on that, I want to ask Dr. Arun Singh. Sir, you have been a national advisor to the Ministry of Health and Family Welfare and several state governments. Currently, you're advising the government of West Bengal. And you have been promoting for nearly a decade on how we can keep pregnancy, birth, and childcare physiologically natural. Having said that, we have increasingly seen in maternal and child health spaces that the physiological and emotional needs of women and newborns are not met. We have seen, unlike what we're seeing in Fernandez Hospital and a lot of other places, that the natural process has been fragmented, and we have separate spaces for antenatal, for delivery, for postnatal. So, how can thoughtful design of space support the natural physiological processes so that we can increase natural birth, decrease unnecessary C-sections, and have more successful early breastfeeding rates?
Thank you very much. I think the first thing to appreciate is that the birth of a child is not a physical phenomenon at all. It is a dream of a mother that my child will cognitively do much better than me. And that dream gets shattered even if there is a normal delivery, but the child has some problem, both short term and long term. Imagine the entire 9 months or 40 weeks she has spent waiting for that D-Day in which a new individual will come to the planet. And when I said it's not a physical phenomenon, you have to appreciate that the baby who is going to be born with 100 billion wires, which we call neurons, and they are going to get connected the moment the child is coming out on this planet. Now, for this 9 months hard work, and for this whole society, the investment is actually in the fetal and the newborn life, because that shapes the entire society and the community. Now try to think about that this entire examination, this entire dream coming true is in that labor room. And if that has not been designed properly, you have messed up. Just because a newborn cries and we all laugh, that's not enough. What you cannot see is how these 100 billion neurons of both the mother and the newborn are getting formed. So, let me now get to the fundamentals of it. We had a design back in 19th century in the government sector where we said home delivery is not good, please come to the institution. And these institutions were designed as moving stages of labor. So for each stage of labor, you had one room and then you needed to be shifted. I would ask ladies and gentlemen to think about that I have come to the hospital and I am told that I have to change my room after a certain period of time. This is going to bring a lot of stress both to them. So the labor rooms were chaotic. We blamed the doctors, we blamed the nurses. What we didn't think of, that the whole design was meant for a failure. So we just heard that labor is not a phenomenon which is entirely limited to the mother's womb. A labor is a phenomenon where the mother's brain works. You just said oxytocin is going to come from the brain. And that brain is controlled by the ambience, the hypothalamus. Right now we are sitting in this hall. How we are feeling depends upon how this hall has been constructed. So if you design such a labor, what are your goals? Your first goal is that the mother should be able to deliver normally. Your second goal is that the child should cry immediately, should have normal transition. Your third goal is he should continue to have breastfeeding. And your last goal is the bonding of the mother and the child is successful. All these goals can only be achieved if you do not come into the way between the mother and the child. Nature had designed it that way. All the animals, all the mammals should deliver. No one shouts at them, please push. No one pulls out the baby. And so when these basic phenomena were done, when we said if the mother doesn't relax, I can't call it a normal delivery. If she requires music, if she requires light, if she requires a birth companion, can we design a room which is giving that privacy, which is giving this? This was a fundamental right of both the mother and the baby. What was the outcome? More C-sections. And after the C-section, we were removing the mother and the child. We said this is mother corner and this is baby corner. Mother is going to be looked after the obstetrician. The baby is going to look after the neonatologist. For 9 months, they stayed together and suddenly we come. So the whole design has to be there. Let us think that the baby is not a baby. It is a potential. It could be a Nobel laureate, it could be a scientist, it could be a painter. Those 100 billion neurons have to be valued and respected. And just because it's a small baby whom anyone can carry on, that is not the proper way to respect your future generation. So, for breastfeeding, even cows will not will not give you milk if you take away privacy. So when you design it in this way, states after states, you just heard the example of Fernandez, there will be more normal deliveries, and more normal deliveries means better cognition, because that is epigenetics. So I end up with it saying, this is a wonderful session. For the first time, I am sitting in a hall where we are not discussing that delivery is only to be managed by the doctor and the nurses. Delivery is to be managed by the architect. And we change our questions. It is, how does a baby want? How does a mother want? They will dictate how the delivery would take place. Their cognition will be our ultimate answer. How we are going to keep them, even if they don't cry, can we keep the cord intact? How did nature want? What is Dr. Singh asking is not important. How did nature design a Homo sapien to be? Let us ask those fundamental questions to the basic nature and then appreciate the journey forward. So I think the 60 minutes of contact after delivery between the mother and the child shapes the whole thing. The whole wiring of the mother and the baby gets connected there. And what we did without realizing, separating them and giving them the first stress. So I think it's time to think this is the most fundamental. You may have less money, but if your fundamentals are correct, it will give a better outcome in every term. Thank you.
Thank you, sir, for making us understand that designing spaces improves the process of delivery also, delivery of care. It's very nice. And moving on the same lines, I move on to Dr. Chellani. So you were part of the landmark study from WHO multi-country trial on the immediate kangaroo mother care, which we call as IKMC. And it was recently published in the New England Journal of Medicine. Implementing this in a busy public hospital like Safdarjung Hospital must have required not just clinical shifts, but spatial transformation too. So what was your experience in redesigning the space to make IKMC possible? And how is this a powerful evidence beginning to influence the national policy and design of MNCH units in India?
Thanks. Dr. Arun, you made my job easier. Now, globally, if you see, the neonatal units are that once the baby is born and the baby is sick, baby is kept inside the newborn unit and the mother is either discharged or mother is in the postnatal ward, and she comes intermittently to provide the evidence-based interventions which we talked about, that early exclusive breast milk feeding, kangaroo mother care. Now the question is, if you want a good coverage and quality, we say exclusive breast milk feeding, we say that baby to be given kangaroo mother care for more than 18 to 20 hours. Now when you are separating them, how it is possible? It is a paradox that which we have set in globally this. So what we did, the study in 5 countries, where we brought the mother from the postnatal ward to stay next to the baby inside the NICU. Now what this happened, when we talk about the nurturing care, nutrition, safety, the good health All these are possible only when you keep the mother and baby together. And we have now made a unit at Safdarjung Hospital, which you mentioned is the busiest hospital. Imagine 80 to 100 deliveries per day, where we have got mom and the baby together 24 into 7. And not only the small baby, every sick baby is with the mother. And mother is a great nurse. You know, we always say that it should be respectful care. How this respectful care will be possible unless we bring them together? So, this is the time we have to redesign our units, and fortunately, the World Health Organization, based on this research, have come out with the new guidelines in November 2022 that all now units have to be redesigned, where you bring the mother's bed inside the NICU. That's number one. Second is, because this trial was done at a tertiary care level, we are also now doing the implementation research at a district level. Is it possible to do that? Yes, it is possible. And now, based on this, Government of India has adopted in our own national guidelines, so that these new guidelines, where mom and baby to be together, not only for the stable babies, remember, for each and every sick baby, so that you are able to provide the best nurturing care which we are asking, which Dr. Arun talked about, the best care where our neurons work, where the proper oxytocin reflex works. And that's the thing which we are hoping it. So now this is very much as a part of this. But yes, we did have the challenges. For this, I think we need to collaborate with our obstetric colleagues, nursing staffs. Till now, we have been working in silos actually. So now this is a kind of a couplet care which we have seen, where the obstetricians come inside and talk about the mother and the baby. And the newborn people, they talk about the mother, so that to provide the quality of care.
Thank you so much, sir. And thank you for showcasing that how even in the public sector in India, this is possible and how that's informing, in fact, the national policy.
In fact, I am happy Dr. Sanjeev is here, and this has been not only included in the public hospital, but private hospitals have also taken a lead in this, and we have got an excellent example at the Amrita Institute of Medical Sciences.
Thank you for sharing that, sir. So moving to Mr. Pritipal, sir, as a former director of projects at Max Healthcare, you have led the planning of very large-scale hospital infrastructure. Given the rising cost of land in cities like Delhi and the need for high return on investment for private hospitals, how can hospitals design space intelligently to both enhance the patient experience, especially for mothers and newborns, and still at the same time ensure value for money?
Thank you, Dr. Abha. Please allow me to use the example of zero separation model, so that audience is able to relate to what I convey in a better way. Now, hospital planning, and particularly this zero space model, has three very critical elements about hospital design: functional flow, adjacency of spaces, and right sizing. Now, this right sizing is related to area per bed, and that is where your point comes when land availability is reducing and project cost is rising. But having said that, what I want to convey here is that this model is not about saving in area, which are very marginal. However, this model provides substantial improvement in patient care and clinical outcomes. And when I say substantial improvements, these improvements have come because of better infection control measures. And I will give an example for that. In a traditional hospital design, the mothers are kept in postnatal wards, and newborns remain in neonatal ICU, which we call as an ICU. And most of the time, these two units need not even be on the same floor. So what happens? These mothers have to frequently visit their newborns to feed, and they have to travel, distance from the outside area, and then, they visit NICUs frequently during the day to feed their babies. Now, what happens? These frequent movements could bring infection, along with these mothers, who visit their babies, and also it compromises the positive pressure which is required for sterility, as well as temperature control. And am I right in my assumption, doctor? If I say a mother travels about 10 times a day to visit her baby in the NICU?
If we say 2 to 3 hours or 2 to 4 hours every 2, but it's usually, if we calculate for 24 hours, it comes something like 12, but
So,
maybe 6 times she will, may not come 6 times also. Very difficult for them also to move across and then come.
So 12 visits make the situation even worse, because imagine a 10-bedded NICU. So there 10 mothers will be coming and going from NICU more than 100 times a day within 24 hours. Now imagine what happens to maintaining the positive pressure, the sterility. And if these mothers and babies, which in this model have been kept together, then sterility as well as operation efficiencies can be far better managed. And that is why we have this tremendous improvement in patient outcome. Thank you.
Thank you so much, sir. Thank you so much for defining and in fact highlighting the problem of mothers who have just delivered, for them to travel so many times and sometimes even at different floors. We want to open it up for questions. Maybe we can take 1 or maximum 2 questions. I just want to ask the organizer how much time we have, and then we would conclude. We have 2 minutes. Okay. So are there any questions from the audience? Anybody more curious to learn about this? Anything for any of the panelists? Any reflections if there are no questions? Yes, sir. Can we have a mic in the front over here? Yes, sir.
So thank you very much. I think this was really interesting to see. Well, what is stopping us from doing it? So, you gave some examples. Does the infrastructure allow us? What is stopping us from doing something which is as important as you mentioned?
Thank you, sir. So, yes, Dr. Arun, please, sir.
So what stops us is our own self. The space has to be created in the brain. At AIIMS, when I tried to say that even if there is an illiterate mother, even if the baby is on a ventilator, the bed of the mother will be next to the child. My entire medical team, neonatologists, were against this. This will add more infection. I was looking at cognition. And ladies and gentlemen, you'll be surprised, if the mother is next to the baby, not only the baby recovers faster, the cognition is better when we started measuring the head circumference. And I'll end up with one thing, which is a very practical science. What were the mothers doing? Whenever a doctor would come to the baby, the mother would say, "Mera bachcha abhi so raha hai." If it is not very necessary, can you feed him a bit later? Can you give him an injection sometime later? Abhi wo kachi neend mein hai. And the science is that is an REM sleep which nature has made for 18 hours. So 18 hours the neurons are getting connected. And if you destroy this, you are destroying the future of this country. So I think the space has to be created here. And as Dr. Chellani said, the obstetrician and the neonatologist must promise for no reason we will separate the mother and the child, right from the labor room to the ICU. Unless and until we promise this, all this talk is not going to make sense. So the problem is here, sir. Once this is addressed, we can find space, we can find solutions.
Thank you so much, sir. I can't conclude better than this. So as we close, I just want to take a moment to reflect on what we have heard today. Space really is an... Ma'am, do you want to say something? Yeah, please go ahead.
I'm Dr. Shweta. I come from Apollo Ayurveda. I'm an Ayurveda gynecologist, specialized in gynecology in Ayurveda. So I'm really happy to see the concept that you discussed today. Because in Ayurveda, we have a concept of Sutikagara, which means the place where the mother moves in when she's nearing her delivery, and she stays there in that specific designed place where she gives birth, along with the attenders and along with a set of drugs and herbs and medicines which can take care of infection control, can take care of the mother's requirements, which is more or less like what is discussed now. So I think we are moving towards what is there in our classicals, which was described previously, focusing on mother and the child. So really happy to hear this, that we are moving there.
Thank you so much, ma'am. Thank you for sharing your reflections. We are actually out of time, so I apologize because I believe the Chief Minister is here. So as we close...
Dr. Abha, can I add in?
Yes.
No, if you go back 200 years or 300 years, that was the process, Doctor. I mean, it was all the same. I think we came in to make it hospital-centric, to make it doctor-centric, to make it nurse-centric, convenience-centric, and that's how the birthing process has become. And so we just need to think about it, and I think creating space in the brain, many people are not aware, and I feel this is also a need that we need to keep talking about it. And all of the healthcare, people who design, you should design it that way and give, because that is a great help when you do that. Thank you so much.
Thank you so much, ma'am. Thank you. Thank you for sharing that. A big round of applause for all the panelists. Thank you. I really want to share my sincere gratitude to all our panelists for really showcasing how space is an important enabler of quality care. And I also want to thank the organizers, both CAHO and the Institute for Healthcare Improvement, for providing us a platform to discuss this important issue. So thank you very much. Please give a big round of applause to all our panelists. A little louder so that we have the energy up. Thank you. Thank you very much.
Thank you very much, chairpersons. Thank you very much, faculties. May I request you to kindly congregate for a group photograph at the stage?